Our research spans both domestic and global policy, and we're very interested in challenges around the globe. But of course, we have many challenges here at home, and so much of our work is on domestic health policy. Our goal is to do research and translate that research in ways that policymakers can use it to try to address some of these very profound problems in our healthcare system in terms of cost, quality, and access.
So a lot of what we do at Stanford Health Policy is speaking directly with state, local, and national public health officials, in agencies, in legislatures, helping them understand what we've learned about policies that are great ideas and work, policies that are great ideas but have been implemented poorly and need adjustment, and policies that seem like great ideas but are disappointing in their results.
The United States spends an enormous amount on healthcare, way more than other countries we might compare ourselves to, and way more than we did in the past. And it's raised a lot of questions for us. Are we getting our money's worth when we spend $3 or $4 trillion a year? Not all of our population has insurance. Many people struggle to get the healthcare that they need despite the high spending that we have. And so this raises really important, deep challenges for us.
When you think about the portfolio of research projects we have, the policies that we're interested in are anything that affects health. So health care does, of course, but so does climate change, so does war, so do refugee crises, the substance use epidemic, gun violence. So we study these topics very, very broadly.
One of the things that I'm really excited to have had the opportunity to work on the past few years is a study of how preeclampsia when you're young affects your cardiovascular health when you're older. And so we designed a study that is funded by the National Institutes of Health, and we are enrolling a few hundred women at different points in their lives to try and understand how this process plays out over the life course. So we're bringing in women who are pregnant and who have preeclampsia or don't. We're bringing back women who had preeclampsia or normal pregnancies 5-10 years later. And then we are, in fact, partnering with people in Denmark to get samples from women who had these problems 20-30 years ago, which we were able to do because Denmark has such great resources.
The population of older adults in this country is growing rapidly, and especially the population of the older old adults, those over age 85. And this is a good thing. This is an indication of people's health and well-being and maintaining their ability to function. But we want to be sure that we prepare for it. And a major health policy issue, I think, is how to honor the preference that most people have to age in place in their home and community rather than to be admitted to a long-term care institution. I see that as a really big policy issue that needs to be addressed.
The environment affects all of us, whether we realize it or not. And just to give one example of some of the work that we're doing to address environmental issues is that we were talking with a group in San Joaquin County. They were interested in how the wildfires are affecting patients, particularly people with cancer, both in terms of risk of cancer onset just from being exposed to the smoke, but also the impact in terms of their ability to have consistent cancer care if there's another wildfire.
Over the last couple of decades, school shootings on school grounds have more than doubled. Even shootings that, do not make the media, right? They might not have very many or even any deaths at all associated with them or any physical injuries even, nevertheless have lasting and important impacts on the students who are there at the schools where they take place. We found that in the aftermath, students who are at these schools have much higher rates of chronic absenteeism. They're more likely to have to repeat a grade. And in the longer term, they're less likely to graduate high school. They're less likely to go to a four-year college. They're less likely to get a bachelor's degree. And then as young adults, they earn less and they're less likely to be employed.
So mass shootings are the most visible form of gun violence in the United States. But in fact, most gun deaths, most of the 40,000 gun deaths each year in this country happen in and around the home. They're private tragedies, and they are mostly firearm suicides and firearm homicides. Our most recent studies have looked at the question of guns as a secondhand risk. So we're not thinking about the person who brought the gun into the house, the gun owner, but the person who lives with the gun owner but doesn't themselves own a gun. Most of the people that fit that profile are women, and there are about 20 million people in the United States that are in that situation. What we found was that their risks of suicide jump by about 50%. Their risks of homicide jump by about threefold, and their risks of being killed with a gun by a domestic partner increase about sevenfold. So these are risks that we've never really fully understood before. We know more about the risks of bringing a lawnmower or a trampoline into the home than we do about firearms.
One of our most important partnerships and collaborations is with the Department of Veterans Affairs. Many of us have worked there for years. I am a primary care clinician and took care of veterans for almost all my career. The collaboration includes both research, teaching, and clinical care.
I'm a co-director of a new center at the VA called the Center for Policy Evaluation. The goal of this center is to combine cutting-edge research methods to ask questions that are policy relevant outside of the usual grant funding mechanism.
In Stanford Health Policy, one of the areas that has been a focus for this group has been in the field of decision science. And that's really all about trying to be systematic and explicit in how we weigh up the different possible choices in front of us in terms of how well they contribute to the things that we're trying to achieve. One of the big initiatives that we are hoping to be able to launch in the near future is the idea of creating a blueprint for investing in technological innovation that will make the biggest potential impact on health over 2 or 3 or 5 decades.
Our goal at Stanford Health Policy is to improve people's health and help them live longer, healthier lives. And so we want to see the impact of our work in the real world.